Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast. My name is Terry Fletcher. It is October 22nd, and I'm really happy to have everybody. Also, thank you so much to those of you that shouted out my birthday last week. I got a lot of birthday wishes on LinkedIn and Instagram and my Facebook page for business. So thank you so much. I really appreciate that. That was just so sweet of you guys. I really appreciate the acknowledgement there. We had a good time. I think my birthday lasted a week, and I'm usually not like that. So I was like, okay, well, it's over now. Let's move on. But it was really a good week. So this week, I'm actually going to revisit a topic that I talked about in May, but there's been some new information that has come out with regard to Incident to billing and advanced practice nurses and physician assistants, etc. So the NPPs, non-physician practitioners, and billing of Incident to, and the MedPAC, which is Medicare Payment Advisory Commission, came out in June on their quarterly report, and they basically told Congress and said they're suggesting that Medicare basically eliminate any kind of Incident to and just have APRNs and PAs, etc., bill directly for their services to Medicare rather than under the National Provider Identifier of the supervising physician or under Incident to. They say that the Incident to rules were established well before the growth, both in the numbers of the PAs and nurse practitioners, and before they realized their importance in the healthcare system. And so it's also hard to differentiate between the services they provide from those provided by the physicians, because Incident to means you're billing it out under the physician. How they kind of talked about this and really made a case for themselves was they said, eliminating the Incident to rule or I should say the Incident to option, they said that it would reduce Medicare spending by $50 million to $250 million the first year, and by $1 billion to $5 billion over the first 5 years, as compared to the current law. And again, they said it's because they get reimbursed under the physician providers number at 100% of the Medicare fee schedule. And it's only 85% of the physician fee schedule when they bill directly to the payer. And so it was kind of surprising to me when the American Association of Nurse Practitioners came out and said, we urge Congress to act on this recommendation as soon as possible. She said it just makes sense as far as now they can have more autonomy. There's not going to be a problem with distinguishing specialists working under the primary care or specialty physician. And it also will help attribute beneficiaries more to accountable care organizations. And also it will shift in specialty selection under the nurse practitioner or PAs, because right now it's hard to say if you're a nurse practitioner or PA, you're basically under the specialty of the physician that you're being supervised by. And there is so much, I don't like to use the word fraud. I hate that word. But there's so many, how about non-compliance and mistakes going on within the Incident to billing that would be eliminated if the physicians found out that they weren't going to get 100%. I've had a couple of clients of mine where when I do a spot check on them and all of a sudden I see something inappropriate or non-compliant, I'm like, whoa, what are you guys doing? So I said, where's the physician here? Why am I seeing a bill for this when I know the doctor is off that day? And it's a real problem. So let's just talk about what it is so you understand right now. Now, I don't know how much weight MedPAC has as far as this implementation going forward soon, but I do know that it's in a very serious discussion. But we want to understand what we're dealing with right now under this limited license option before it goes any further, so that you know that you need to follow the rules. You want to make sure you're not at risk, and we need to be reminded of what those are. So Incident to billing for advanced practice providers, and that means nurse practitioners, physician assistants, clinical nurse practitioners, nurse midwives, etc. That has been available since 1998. And the rules for what is required to bill Incident to are clearly defined by Medicare, CMS. But this privilege, again, which enables a limited licensed practitioner, that's what we call them from a administrative perspective. It allows them to bill under the physician, and the practice gets paid at the full physician fee schedule rather than the 85%, but it is continually abused. I got a direct message from somebody recently from my Twitter account, and she was working for the emergency department physician and said that this doctor was billing Incident to in the emergency department and getting paid from Medicare, and she was concerned because he wasn't supposed to be billing it out Incident to from her understanding. And she was right. There's no Incident to in a facility setting, only in the office setting. And also, if you're in the ER, you don't see typically established patients if that's your role in the ER. You're seeing patients who are coming in for the first time because you don't follow up as an ER physician with patients who come in for first aid or ER treatment. You then have to find them another physician who they follow up with. So it's just, there's so much abuse out there. And what I'm seeing in some practices is that they are basically saying that the physician's there, they're not, or they're billing things under the physician that is the patient's physician and not actually the physician that supervised. So let's look at what is required to bill under Incident to under the current Medicare regulations. And keep in mind that these rules apply to Part B Medicare patients. If a patient has Medicaid, Medicare Advantage, or is not a Medicare patient, the rules for that patient's insurance company must be determined before billing Incident to. Do not assume the patient's payer follows Medicare rules. They may not. So for Incident to exist, the following conditions and rules must exist. So the services provided in the office. Incident to services may not be provided in a facility, which includes but is not limited to outpatient clinics, emergency department, inpatient, or SNFs, skilled nursing facilities. The advanced practice practitioner is following a care plan that's been established by the patient's physician. That means if the plan of care is changed, for example, prescription drug management. Now, if they change the amount of the prescription that's already prescribed, I think that's a gray area. But let's just say they prescribed, this kind of medication for hypertension, and they're like, no, that's not working. So we're going to change it because your clinical profile is showing that you have an exacerbation or a problem of not being controlled. Then that plan of care is no longer being followed, and the visit no longer applies for Incident to. The APP is under direct supervision of a physician. That means that there's a physician in the office suite. It does not mean that there's a physician on a different floor in the same building or in the hospital attached to the office building or available by phone. The physician must be in the same office suite as the nurse practitioner PA when Incident to services are provided. Also, the supervising physician doesn't have to be the patient's physician who established the plan of care. It's the physician, again, who is supervising the APP. They're actually in the office. Also, a best practice now would be for the APP to document in the chart and, Dr. Smith in the office supervising today, and then move on with what they're saying. That just establishes the presence of a supervising physician in the office. And one of the biggest fatal errors is billing the Incident to service under the patient's physician and not the supervising physician. I see that all the time. Now, when I mentioned do not assume that the Medicare payer or Medicaid payer follows Medicare Part B just because Medicaid is part of CMS, some state Medicaid programs, and remember, Medicaid goes state to state. For example, here in California, we call it Medi-Cal. In Arizona, they call it Access. So it just depends on what program it is. In Kansas, by the way, they do not allow Incident to billing of APPs. They pay 75% of their fee schedule when a APP delivers a service, and it has to be direct billed. So if you bill an APP Incident to in Kansas or any state Medicaid program that has a similar rule, it's considered fraudulent and you'll get in trouble. So I've had a couple practices that have done that and they got in trouble. Then they come to me after the fact and say, oh my gosh, can you help us out of this? So as you can see, there are many ways in which visits can violate the Incident to rules. And without an audit, your Medicare carrier won't actually know if your rules have been violated, since the claim for an Incident to service looks exactly like the claim from the supervising doctor. Audits are triggered when CMS sees a significant number of services, typically in one day for a single physician, because both the provider and the nurse practitioner PA are billing under the physician's National Provider Identifier, the NPI. And there's really no modifier or other method under Medicare that a claim is coming from an incident to provider. Now, some private payers have been able to differentiate. So, for example, United Healthcare, they had a policy that came out this year, and it's 2019 R50098. And this policy basically said the SA modifier, so S as in Sam, A as in Apple, is a payable modifier and should be used by the supervising physician on behalf of the advanced practice healthcare providers when billed. So because it's difficult to manage the correct billing of incident to services, some practices have made the decision to just accept the 15% loss for the few true incident to service, and they'll always bill the APP services under their own NPI. So that way you don't have to worry about billing requirements. Now, do I recommend that? It really depends on the practice and how well they're being policed. I mentioned this not too long ago in a podcast I did as far as policing coders, or basically just keeping you on your toes and making sure that you're being evaluated. This is one of the top RAC audit issues, and it has to be policed because it's amazing how many practices will do the correct thing and they'll use their mid-levels and everything's going along great, and then all of a sudden you see a non-compliant situation and it's a problem. But here are some rules that come. What I did is paraphrase some of the rules before, but this comes from a detail from Medicare Benefit Policy Manual, Chapter 15, Section 60. And I just want to give you some of this so that you can look this up and you can understand this. So number 1 would be Incident 2 applies only to Medicare. It does not apply to services for a patient with their own benefit category. So diagnostic tests, for example, are subject to their own coverage requirement, depending on the particular test, meaning that diagnostic tests have supervision requirements that may be more or less stringent than supervision requirements for services and supplies furnished under Incident 2. So make sure that you're aware of that. So one of the other rules, or should say one of the other guidelines in the Medicare Benefit Policy Manual, Chapter 15, it says the service billed Incident 2 must take place in a non-institutional setting. So that means that it's not hospital, it's non-skilled nursing facility, anything like that. It says that hospital services incident to a physician or other practitioner services rendered to outpatients and partial hospital services may not be covered. So they want you to just be aware that institutional setting is not under Incident 2. So it has to be non-institutional setting. Then it says Incident 2 services cannot be rendered on the patient's first visit or if a change to the plan of care occurs. Well, that's pretty clear. A Medicare credentialed physician must initiate the patient's care. If the patient has a new complaint, the physician must conduct an initial evaluation. Now, there's a question about a worsened complaint. Well, if it is an exacerbation of an existing complaint and something's being adjusted that was already given to that patient and now they're established and they're just adjusting the same issue, it's a gray area. But if it's a worsened complaint that they're changing the situation and the plan of care for that patient, then that has to be established by the physician and they've got to step in, or it's billed directly under the nurse practitioner PA. Subsequent to the encounter during which the physician establishes at a diagnosis and initiates plan of care, direct supervision of the qualified provider must be there. And they talk about this. They said direct supervision in the office setting does not mean that the physician has to be in the same room with his or her aide. However, the physician must be present in the office suite and immediately available to provide assistance and direction throughout the time the aide is providing services. I bet you the nurse practitioners hate that word aide. And then they just talk about if auxiliary personnel perform services outside the office setting, so in their home or in an institution that's other than hospital or SNF, Their services may be covered incident to only if there's direct supervision by the physician. So the doctor has to be physically able to and present to oversee the care. Okay, so and it says any member of the group may be present in the office to supervise. And that's the one who actually has to get credit for the billing. I think one thing that's missed with Incident 2 is that it says a physician must actively participate in and manage the patient's course of treatment. And this requirement typically is defined by individual state licensure situations under supervision, but your physician does need to eventually see the patient again. And then it says both the credentialed physician and the qualified NPP providing the Incident 2 service must be employed by the person billing for it. So if a sole practitioner, the physician must employ the NPP. So make sure it's not somebody you're borrowing from the hospital. And it also must be a service that you routinely provide in your office. And then make sure that you understand that services meeting all of the requirements I just mentioned. It may be billed under the supervising physician. So it can't be just you're meeting some of those requirements. And to give you an example, general practitioner diagnoses a Medicare patient with hypertension and diabetes in January and creates a plan of care. The patient returns for a follow-up in March with the nurse practitioner. At the follow-up visit, the patient now complains of knee pain and swelling. And so even though the physician is in the office, the nurse practitioner now evaluates and treats the patient for the new problem. This is not now considered Incident 2. It doesn't meet the requirement. If they had only evaluated the hypertension and diabetes, then yes, they could bill for it. But because the physician did not personally perform the initial service for the patient's new complaint of knee pain and swelling, the service cannot be reported as Incident 2, and now it has to be billed out under the NPP, under their own ID number. Even if half the visit was about the Incident 2 plan of care and the other half wasn't, you still can't do it. It's basically collectively, what was that visit about? Similarly, if the physician assistant sees Medicare patients in the office while the physician is at the hospital making rounds, Incident 2 is not appropriate because the requirement for direct supervision was not met. The physician has to be physically present in the office suite. And so just be aware of this, because these rules are just so important to make sure that you're covering them. Otherwise, you could really find that you're in a lot of trouble. And I just don't want to see you have some non-compliance. But MedPAC is really trying to get this eliminated, where it's just billed direct. And I could see that happening in the near future. And again, this is under Medicare Benefit Policy Manual, Chapter 15, Section 60, if you ever want to look it up. So I have a coding question today that came from somebody who listens to the podcast, and I won't call out the person only because I think that they'd prefer that I keep them anonymous, only because they're calling out their practice. But I'm going to give the information, and then you can, kind of take it for what it is. So they said, here is the question. And she's like, so there's a problem within their office where they bill a preventative visit and also bill a 99212 code, but they only bill it only if there's a diagnosis. They don't bill it because something else is being addressed. So she says, I don't even know if I have a question here. I just feel there's some creative billing going on. They're adding the 99212 for contraceptive counseling or obesity and other diagnoses that are part of the preventative visit. And I think those will be denied anyway. But they're going back and actually billing all of these 99212s on the same day as a preventative service. So let's talk about that for a second from a question standpoint. Preventative services are age-appropriate in the E&M section services that basically are billed when you have a patient that's coming in for what they basically call age-focused services that just talk to the patient about how they can, it's anonymous to call it trivial, but it's an evaluation and management of a patient that has an appropriate history, an exam, counseling, anticipatory guidance, risk factor reduction. Basically they're not complaining of anything. They just have certain age appropriate situations going on. One of the things that, that they talk about in this is basically what she was talking about, contraception, when you talk about smoking issues, obesity issues, lifestyle. It's basically like, this is how old you are, this is what you should be doing, and this is what it looks like, and there's a possibility you could get sick if you don't follow our preventative. Think of the definition of the code of our preventative medicine service recommendations. Now, when should you be able to charge for an office visit in addition to a preventative service? Well, here's what CPT says. If an abnormality is encountered or a pre-existing problem is addressed in the process of performing this preventative medicine evaluation and management service, and if the problem or abnormality is significant enough to require additional work to perform the key components of a problem-oriented E&M service, then the appropriate outpatient visit code with the modifier 25 should be added to the office visit code to indicate that a significant, separately identifiable E&M service was provided on the same date as the preventative medicine. So an insignificant or trivial problem or abnormality that is encountered in the process of performing preventative medicine evaluation and management service and does not require additional work and the performance of the key components is not appropriate. And I think in answer to that question, I don't think they have a medically necessary reason, and I would have a field day with that the entire time. So I think you're correct to question it, and it's inappropriate. And the other thing, keep in mind, if you are doing a preventative medicine service and you are trying to use the 25 modifier for an additional office visit, first of all, a couple of things you have to realize what's going on. Patient's going to have two copays, one for the preventative service, one for the sick appointment, I call them. So the office visit. Secondly, you're using a 25 modifier for protection to try to get paid for both. So you would have to have a separate diagnosis showing an active problem or abnormality that you had to address. And third, there's actually a third thing going on, is that you're using a 25 modifier. Again, that says significant separate service. And so what is significant about a level 2? Nothing. And so you have to really be cautioned about that. And I think that would be a non-compliant way to capture something that is not accurate. So hopefully that answers your question and they listen to your advice at your practice. Our coding question was brought to you today by Medical Economics, Smarter Business, Better Patient Care. Follow them for the latest news and viewpoints on primary care, the business of medicine, and health IT. medicaleconomics.com. So my personal tidbit today is I'm going to give you a pet peeve. I'm really annoyed. One thing I don't like is wasteful spending. I just don't like it. And if you've met my daughter, you'll know that we butt heads about that all the time. But I had to get a new phone because my iPhone 6 Plus before was losing charge. So every 3 hours I was having to charge it with was not fun. And so I got an 8 Plus. And I probably should have got the X, but they didn't have the Plus at the time. And I like the bigger phone, especially since I look at email and that quite a bit. But I was on an airplane when I went up to Oregon last week, which I mentioned, and they don't have the adapter. So the plug that you put into your phone, because I was listening to a book on tape on the airplane, didn't fit into my phone for my headphones. And so then I had to go spend money on an adapter. Now, when you get it off Amazon, you can get 2 of these little adapters, which basically is the thing you plug into your jack you plug into, and then you can plug it in your phone because now it works, for $8. But if you buy it in the airport, it's $19.99 for the same exact thing. So I'm a little annoyed. I realize $20 may not mean a lot to you, but it means a lot to me only because it bugs me. It's not if you have the money, it's why should you have to spend the money? You should include that adapter. And my daughter and my friends were like, hey, I think it's part of your phone. I looked in my phone box. It wasn't in there. So either it was missing, I'm not sure, but I didn't get a little one of those adapters, so I had to go buy one. So anyway, just bugged me. See, I do have that petty side. For those of you who've been listening to my podcast now for almost 2 years, gosh, can I believe that? Almost 2 years. You know, I do have a snarky side, but I'm in a very good mood. It's just something that I just thought it'd be funny to bring up. Because I'm sure every once in a while you're like, why do we have to spend money on that when we don't have to, or shouldn't have to? So that bugs me. But anyway, I hope everyone has a great week and make it a great day today. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terrycoder1.com. www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.